Dr. Boyer, it's a real privilege and a pleasure to speak to you today. Tell us a little bit about the broad scope of your work.
Well, I've been involved in clinical trials for the early HIV days and have been fortunate enough to participate in all the early wet macular degeneration trials, including the trials for ranibizumab, the Sageler trial, and the trials for EYLEA. And it's been a real pleasure to take care of patients and start to see patients that were previously untreatable become treatable. And we've continued, we've worked in the vascular occlusions, diabetes, and now we're really focusing a lot of our efforts into dry macular degeneration.
Tell us about some of the work that you'll be presenting at AAO 2017.
Well, I'm going to be presenting some of the upcoming therapies, and this is a changing field, and in the last, unfortunately, 2 days we've learned that one of the promising drugs that was in the pipeline actually did not make its primary endpoints, which was very disappointing. So I basically think that you need to realize we don't have an animal model for dry macular degeneration, which puts us at a major disadvantage to be able to test drugs. We don't have this good model that we do have for wet macular degeneration, which makes it much easier. We can throw a lot of drugs at the models and see which one's best. In this case, we really can't. So there are different approaches that have been taken, many of which unfortunately have failed up till now. I discussed some of the ways that you can approach macular degeneration. You can do reduce oxidative stress. That's been tried in the form of drops and different vitamins. You can look at neuroprotection, and I did speak about brimonidine, which actually does have a neuroprotective effect. It reduces damage to both the ganglion cells and actually the photoreceptors in models like ischemic model, the nerve crush model. So all of these, we're very favorable toward the possibility that it would work. And certainly when they tested 2 doses, a low dose of 132 and a high dose of 264 micrograms with 6 months intervals, and actually with a readout at 6 months, 5 months after the last treatment, they did show an improvement in the size of the geographic atrophy. It was dose related, meaning that the high dose decrease the growth of the GA more than low dose. So this is a very promising area. It's not inflammatory, it's not other pathways. This is actually a neuroprotection, which may be used in combination with other treatments. I also spoke about the fact that some people believe that geographic atrophy is related to poor blood supply. So Macular is a topical drop. They've shown to be effective in improving the blood flow in the retina and in the choroid. And by doing this, they're hoping that they can reduce progression of the geographic atrophy. I think in my discussion, I was limited by time, but there's been a lot of work done on the complement system in the treatment of dry macular degeneration. It's based upon the fact that we know histopathologically complement's involved in drusen, and we feel that the inflammatory pathways can be downregulated and hopefully reduce the MAC complex formation and eventual destruction of the cells and a reduction in the growth. The most promising happened to be lampalizumab, which was a factor D inhibitor. It worked in the alternative pathway, the complement pathway. As you are aware, there are 3 basic pathways. There's a classical, the lecithin, and the alternate pathway, and this worked in the alternate pathway. It reduced the formation of C3b, which would combine with C5, and eventually reduce the MAC complex. That was the theory behind it. And they had an excellent phase 2 large trial that they were able to show that in patients overall, when they treat them, there was a 20% reduction However, the most striking thing was that if you had factor I, which is one of the factors they tested for, you actually approach 44% in that group, but the group that did not have factor I did not improve. So based upon that, a more formal study was performed called Spectri and Chroma, and we were very similar. The one treatment was given monthly, one was given every 6 weeks. We were extremely hopeful that this would play a role in being able to reduce progression. And unfortunately, it was announced that one of the trials was did not show any specific improvement, and the other trial was released that morning that it also did not show any improvement. So unfortunately, people starting to cast aspersions on the complement pathway because we've had a number of failed attempts at trying to modulate the pathway. I think it's important, however, because the next part of my presentation talked about a drug that was positive, which was the Apellis drug, APL-2, actually showed a significant improvement in the growth of the lesion, whether you looked at the general growth or you looked at the square root of the growth. In both cases, it showed a definite reduction in the production, in the GA progressing. So, and I tried to explain how the trial worked. It was a 2-to-2 to 1-to-1, and essentially in that trial, they treated approximately, let's say, 80 patients in each group, the monthly or the every other month, and then half the number of 40 in the sham monthly or the sham every other month. And they were able to show, again, a drug response that where you had about 28% of the patients responding with a reduction, a 28% reduction in growth in the high dose and approximately a 20% in the every other month, or what I would call a lower dose or lower drug exposure. So I don't think that the complement pathway is dead. I talked about the C5 inhibitor. APL-2 is a C3 inhibitor. It blocks the C3 from going to C3A and C3B, and eventually blocks all the way down, all the way to the MAC complex. I'm familiar with that drug because we tested the POT4 when it was originally POT4, POT4. And in that study, Dr. Philip Rosenfeld and I both had patients, and this is being tested in wet macular degeneration. We both had patients that actually dried up. So we knew there was a biological effect from administering this drug. Now, a C5 inhibitor that's being tested right now is a Aptamir it's called Zimira. And Zimira is now, based upon the results of the APL-2 Philly trial, has reduced the number of patients and is shortening their time point. So hopefully they will also have a readout, hopefully in the future. The most interesting, one of the most interesting compounds is a gene therapy, which does a CD59 upregulation, which is a natural occurring protein. And you're able to block the MAC complex, which is the end stage of the complement pathway, and is probably the stage that causes apoptosis and loss of vision. This is from very bright people out of Tufts, Jay Duker and Elias Rochelle, and they are in a phase 1 at this moment, and hopefully we'll get to a phase 2 in the very near future, and it seems that the drug seems to be doing well. For sake of time, I couldn't go through another 10 or 15 different potential treatments that are in earlier stages, but there are a lot of treatments that are out there that are available, or will be available.
So in terms of the current work that you're doing, what are the next items in the pipeline?
Well, the closest, the two that are going to do phase 3 trials is brimonidine and the APL-2. Those two have completed successful phase 2 trials with no side effect profile in the brimonidine. APL-2 did show an upregulation in patients who developed an exudative area of macular degeneration. It did not affect the size of the lesion or the vision, but is something that has to be dealt with. And there was also 2 cases of endophthalmitis, and as you know, in a monthly treatment, one in the every other month. And as you know, C3 is important for oxygenation of bacteria. I don't think that's what caused it. These were staph coagulase negative, very common bacteria, and the patients did well. However, it does make us pause for a second. But those two are the closest to going to a stage 3 trial, basically, a phase 3 trial. There are a number of others that are being tested right now. There's lumitherapy, which is the use of light. And the use of light is very interesting because certain wavelengths of light will upregulate different chemicals within the eye itself. And they've had some preliminary phase 1 trial, and they're doing a phase 2 currently, and hopefully we'll have results very soon. People are doing subthreshold laser. There's a TOGA trial using tetracycline, oxycycline actually, hoping that metallic proteases and the anti-inflammatory. And recently, out of Boston, there was a very interesting study using very high dose anti-cholesterol medication showing a reduction in drusen, and that was published out of Mass Pioneer. So I think it's very exciting time. It's limited because we don't have a good animal model. It's also limited by the fact that we probably need to treat very early when people are almost asymptomatic. If you look at all the trials that are treating, the first 6 months, the cells continue to die basically. So it's in the second 6 months and thereafter that you start to see a very major improvement in some of these trials. So.
Tell us about what the implications for patients are of this current work. What is the trajectory for patients?
Well, we know that macular degeneration is the leading cause of decreased vision in people above the age of 64. And if you look at that population, 1/3 of those are secondary to dry geographic atrophy, and the other 2/3 are secondary to wet macular degeneration. But we know wet macular degeneration also develops a form of atrophy, perhaps not geographic atrophy. I think for patients at this time, I think it's very hopeful that in the next 5 years that we will have a treatment that may be very helpful to them. I wish I could say it was in the next year, but I don't see anything on the market today that's going to be out in a year. And if we start these clinical trials, it takes a year to enroll them sometimes, and hopefully they can be enrolled quickly. They are trials that require at least a year of observation, sometimes 18 months to really see a separation, because you're really looking at the long term. But I think it's very hopeful that once we have this treatment, we can take patients that may be asymptomatic and stop them from losing vision long term. Patients who unfortunately have lost vision centrally, everybody's hopeful stem cells will be helpful, and certainly that's being investigated very vigorously. But up till now, no stem cells treatment has been shown to be beneficial for improvement of vision. Some of the trials have ceased because there was not an efficacy by putting the stem cells there, though they found it to be safe. And some of them, the stem cell trials are showing a reduction in growth of the GA, very similar to what we're getting with these injections. The good news is you may only have to do this operation one time to stop the growth. So I think we're hopeful that we will have some treatments available, and hopefully these phase 2 trials will translate to good results in a phase 3.
Excellent. Thank you so much. We
Thank
really
you very
appreciate
much.
it.